Okay. Well, hello, everyone. You are joining us today. We are the Pediatric Mental Health Care Access PMHCA QI Collaborative, EIC-sponsored collaborative. We are welcoming you back. Our first session was a long time ago, feels like February. So I am going to be joined by a number of my colleagues, my wonderful colleagues, who are going to help us to run the session smoothly. Their names are Hannah De Hoyas, Eleni Belouris, Dr. Sherry Snyder, and others joining. I'm not sure if everyone has jumped on, but they will be in a second. So welcome, welcome. So this is our April collaborative session, and we are ready to get started. Our agenda, we'll talk about an overview of a SMART aim and measures concepts today. We'll talk about your experiences and your measures that you're working on and how you're identifying them, which is the most exciting part for me. And then we'll talk about next steps. Just a quick recap, welcome back. Remember in February, we have introduced a number of stakeholders that could be helpful to your ED expansion projects. There were emergency departments that we had join us in the past from ED Stop Collaborative that we had in 2023. We also had emergency medical services for children state partners programs who had joined us during that time. And had collaborated during the first February collaborative. Just a quick reminder, if you do need a soft introduction to any of the stakeholders in your state, please let us know because we can help with that. Also, there are a few folks who had reached out, a couple, from a couple of states actually, and had asked if these stakeholders, EDs and EMAC state partners, can join to our future sessions? And the answer is yes. Please just let us know, or they can just click, go on our website and join. Our next, the larger group collaborative will be on September 12th, and we would love to welcome them back. All right, and with that being said, we wanted to one more time go over our objectives, which is a SMART aim and measure identification. So this particular session is focused on PMHCA teleconsultation provider to provider, engaging with ED providers by offering provider to provider consultations. There are several examples here on the screen how one can go doing about this and how can one get engagement happening. This is not limited by any stretch of imagination. There are many other ways, but I do encourage you, if you haven't done so, or if you're new and haven't heard, we have a great partner with us who are participating in this year collaborative as a consultant, Ryan Baker, with North Carolina NC STEP, which is a statewide telepsychiatry program. If you'd like to learn more, please review the webinar we had with him in March, just recently. That's available on our website. Also, Ryan welcomes every single question or concerns or anything he can help brainstorm ideas with. So he's made himself available to us. So please keep that in mind. A quick overview of a SMART aim. We know that the SMART aim should be specific, measurable, achievable, realistic, and time-bound. It is much more narrow and much more measurable than a global aim. And we did have a webinar on February 1st. Quick reminder that went into details how to draft one. I also want to remind folks that we are available at any time your group needs help or team needs consultation on how how to do this and where to get started. And the next slide has an example of very simple, but a very powerful SMART aim that one of our teams have drafted in the past. Just wanted to make everyone aware of that. And do want to do a quick reminder that we might, have been working on for a long time and doing this work and very well aware. But when one talks about measures in healthcare, we often refer to the Dynabedian framework. That's the model that can be used to understand measures in the context of healthcare delivery. There are three types of measures: structures, measure, which is the setting or environment where care can be provided; process, which is where the delivery methods and coordination of care that occurs within the setting; and the outcome, which can focus on health of the patient or population we serve. Do you want a quick referral back? We just had a webinar on March 26th. Which was webinar/office hour. The second part of it has a great explanation and more importantly, a deep dive of how to evaluate and look at the measures. With that, I think this is the beginning of my first of my spiel, and I am just so excited and very ready for your presentations. I do believe I'm going to stop sharing. I do believe our first team is Washington to present. Do I have Washington joining us?
Yep, we're here. We're here.
Awesome. Okay, do you guys want me to stop then and let you share?
That would be great.
All right. Well, welcome.
Thanks for having us. Well, let me see. Too many windows open. Hang on here.
It's okay. And while Renee is looking for that presentation, she's been a great partner and in this endeavor and helping our team to learn more about PMHCA throughout the last year. And we've gotten to know Renee a lot, and Washington team there have been very, very helpful.
Okay, can you see my slides?
Yes, we can see.
Okay, perfect. Let me just rearrange things so that let me put it in presentation mode. Does not want to, there it goes. Okay. Let's get all these little pop-ups on things on the PowerPoint that I don't want on. Okay. Hi, everybody. I'm Renee Tinder, and I'm the project manager for the PMHCA grant in Washington State. And I am joined today by Pauline Ray, who I will let introduce herself in just a second. And we are going to just, Pauline's going to kick us off with a little, just a brief overview of our ED project, and then we'll jump into the slides that were provided to us, and then end with just a few follow-up slides on some of our data sources, etc. So Pauline, I'm going to kick it off to you.
Thanks, Renee. So as Renee mentioned, my name is Pauline Ray. I'm a clinical social worker by background. I'm the program manager for the Seattle Children's Mental Health Hospital Consultation Service, which we actually just launched this week. So we're super excited to be up and running. And we are a provider-to-provider consultation model, providing pediatric mental health support across the state of Washington. So we're providing consultations to ED providers about their pediatric mental health patients, primarily patients who are stuck boarding in emergency rooms and have complicated discharges or no place to go. So that is our aim. We are utilizing like an education-based, suggestion-based model. We're also going to be holding we call them provider cafes and office hours as a place for our providers to come to get further support and learn more about our team. Our team consists of myself, I'm the mental health therapist, program manager, case manager role on the team. I am joined by a BCBA provider and currently 3 psychiatrists. So we try to provide comprehensive services, both with behavior support, medication management, and then resource navigation as part of our team. And I will kick it back to Renee for our slides.
Great, thanks, Pauline. Yes, we were very excited that the program has launched. So for everyone else on the call, stay the course. It might be an uphill battle, but there is exciting things ahead. So we're just really thrilled that we're finally are able to accept referrals. So let's see, clicking forward. There we go. Okay. I was not able to modify this slide. I'm not entirely sure why, so I just left it in there, but I went ahead and just put in our SMART aim statement. And I've reread it about 75 times in the last 24 hours, and I'm realizing now it does feel a little wordy. So again, with a QI project, I think it's again something that's always under construction. So the
Renee,
aim
we
that,
can't see your slide, the slide
oh,
you show, and for some reason we see only PMHCA Washington State.
well, goodness gracious.
Maybe just
Okay.
reshare. Sometimes that
Yeah,
helps.
hang on.
Yeah, yep.
That is, let me see, hang on. You know what I think is happening is I think I've got,
Well, we know how we all love technology.
geez, I know, right? The technology. Oh, goodness. Okay. Is
There
that
you
better?
go. Yes, we can
Okay.
see smart aim
Perfect.
statement. Yes, yes.
Awesome. Thanks, Anna.
Yeah.
So our SMART aim we came up with was by providing peer consultation and resources to emergency department providers, we will change provider comfort level with the pediatric mental health population, which will result in over 50% of providers surveyed reporting increased comfort caring for pediatric patients with mental health needs by March of 2025. So this was sort of just kind of the process that Pauline and Brooke Rosen, who is the child psychiatrist on the project, that we went through to build that SMART aim. So Pauline alluded to this, where the who and what is providing consultations, peer-to-peer consultations, and resources and education to providers in EDs across the state of Washington. We're going to be measuring how providers' confidence essentially in how they felt pre and post. It's Pauline's going to talk about the survey after I'm done. We want to see over 50% of the providers that we survey saying that they feel more confident caring for the pediatric patients that they see in the ED once they've had this consultation service with our children's staff. We're going to do this through consultation to providers in hospitals that don't have access to pediatric mental health specialists, which Pauline will also talk about the needs assessment that we did, the Seattle Children's team did to get feedback on what was needed in hospitals throughout the state. And that's going to be measured through these post-consultation surveys to providers assessing their satisfaction with the service. Why does this matter? I mean, you all know why this matters. Our workforce in child and adolescent health is limited, and we need to find ways to increase capacity to serve youth with mental health needs. This is there's a huge gap in accessing services and services to youth. So we want to expand that access to care in, starting small, but we hope to grow, respond to this needs assessment findings that providers didn't feel comfortable addressing mental health needs of pediatric patients in their care. And again, we'll show you those results here in just a minute. And then our time bound is by March 2025, which is a year away. But like I said, this project, we've been underway for, I think we're in year 2 of a lot of a labor of love, of a lot of hurdles and a lot of roadblocks. And so we're finally on our way. So in a year, it will be really interesting to see if we've hit this SMART goal. Okay, so what is our M? We want to have a high response to that post-intervention satisfaction survey. And again, we want the majority of providers to indicate that this helps, this service, it increased their level of comfort and skills in supporting the patients that they're seeing that have mental health needs. So these are some of the sources that were used to inform the work we're doing kind of from the beginning. And also now when we were drafting this, the SMART AIM, we were discussing how this played into what we wanted to see our measurable change be. So Seattle Children's did a statewide mental health needs assessment, which Pauline will talk about. We've got a post-intervention survey that has been developed. And then the Northwest Healthcare Response Network, which was organized during COVID, they've provided some youth hospital boarding data that we're using anecdotally. It's not unduplicated, so it's I don't want to say squishy, but it's not, you know, it's good data, but we're using it just as one other piece to inform the work we're doing, and hoping to get more solid data as we move forward with that. So let's see. Okay, I'll turn it back to Pauline to talk more about the data points.
All right, so one of the first things we did, even prior to launching our program, as Renee mentioned, is that we conducted a statewide mental health needs assessment across the state of Washington. Currently, we have 37 respondents across the state. We are hoping to increase that number as we roll out our program. We will be sending out the pre-intervention survey to providers who call in to access our services, hoping to get more responses. As you can see kind of from this data, the predominant respondents to the survey were medical providers and hospital administrators. And what we're hoping for is more boots on the ground responses from the nurses, the ED physicians, the social workers working with the patients in the emergency rooms, who are really the front line. So we are hoping to gather more data as we go along there. And we all, as Renee mentioned, we are using that data from the Northwest Healthcare Response Network to inform the survey as well. That data tells us which hospitals across the state have the most pediatric mental health boarders. So we will be reaching out to those hospitals directly, most likely directly into their emergency rooms, to try to, one, market our services, let them know that we exist, and also assess their needs, right? So they're the ones that have the most pediatric stuck patients that we can see, at least from the data. You can go to the next slide, please. So this is something interesting that we learned. So in response to the SMART AIM that Renee was talking about comfort working with pediatric mental health patients, on our initial survey, we learned that 78% of our respondents report that caring for pediatric mental health patients negatively impacts their job satisfaction. 24% reported an extreme negative impact. And so we are hoping, as Renee mentioned, with our SMART AIM, to get that number into the green, into a positive skew, having more than 50% of them reporting a positive experience working with pediatric mental health patients, if we can provide them with needed mental health resources. So we are hoping to make a big impact there with our program. Next slide, please. And this is just, so we are, as I mentioned before, peer-to-peer consultation model. So we will not be zooming into hospital emergency rooms to provide telehealth services to patients and families. We actually, as had originally wanted, a direct care model, as is pictured on the right-hand side of this slide, and that was our original goal. But as Renee mentioned, over the last year, we encountered a lot of barriers with that model, with hospital contracts and just many barriers to providing direct care. So we ended up with a consultation model that we're hoping, perhaps if it goes well, to eventually expand to that direct care patient model in the future. And I think that's it for me. If anybody has any questions, let us know.
Thank
Thanks,
you so
Pauline.
much.
Oh, whoops, sorry. I'm going to
Go
stop
ahead.
sharing. Nope, I was just going to say that's the end of the slides, but yeah, we're happy to
We
answer
do
any.
have actually a few minutes. I like to encourage folks to ask questions. I do have preset questions, which we will address at the end, but actually for your group, we have 2 to 3 minutes for group discussion questions. And so I want to give a little bit of time. All right, not seeing any unless Hannah, Eleni, do you guys see any questions? All right. And Eleni, I wanted to
No.
thank you. I want to rely on your note taken. Did we address all the questions we needed to address with Washington?
Yes, we did.
Thank you. All right, I have Michigan. I have your slides and ready to present them. Are you guys ready to go?
Yeah, we are ready to go. Thank you so much.
You're welcome. Give me just 1 second.
Thank
All
you.
right, share screen.
While that's getting set up, my name's Nasu Malas. I am the medical lead or clinical lead for our Michigan MC3 teleconsultation expansion to EDs. I'm joined by several members of our team, Ann Kramer, Sheila Marcus, and Elizabeth Tingelich. And then Mary Lutke's our partner at the state level. So we will present on our program here.
Can you guys see the slides? Says PMHCA State Michigan.
Yes.
Okay.
We can go to the next slide. So we are fairly in the infancy of this expansion. We started our efforts in November, so we're a little over 5 months into the effort. And our focus right now is on design and development, and we will be shifting to implementation and pivoting our view more towards outcome and process measurements once our program is kind of more developed and designed. So our SMART aim currently is in that context and is identified as MC3, our consultation program, identifying and developing criteria, team, and consultation models for the emergency service by the end of FY24. And kind of looking at the different components, we really are trying to understand how we can adapt a very successful primary care and perinatal program to the particularities and needs of the ED setting, recognizing we have a very diverse population in Michigan, just as many of our other states, with rural settings, urban settings, and everything in between, populations with a variety of needs, an ED that has a variety of different levels of acuity, different times a day, and days of the week that we need to attend to, as well as staff that have differential needs. And so we really are focused right now on building that model, as well as who needs to be part of that model and accounting for that diversity. So the first measurable is we want to identify who that core team is, and that includes the core members of the MC3 team and who we need to engage, as well as who are our key stakeholders and partners in the development of this, including the pilot sites we've identified. Identify inclusion criteria. What is our scope of practice? What are the necessary requirements of those pilot sites to participate in the pilot so that we can ensure there's effective communication and safe delivery of consultation, as well as how will that model look. And we mentioned in the previous presentation with Washington, the idea of boarding and supporting patients that are boarding. That's the reality of the care we need to deliver in the ER. Is that's a big issue. And how do we model boarding when there's significant transitions in care and other kind of systems issues that may be impacting boarding, and being effective along the domains of both disposition management, therapeutic service delivery, and other behavioral interventions, as well as pharmacologic consultation. In terms of our actionable, we want to ensure there's adequate resources for model development and work with ES stakeholders. So making sure we understand the site's needs, their demographics, their workflows, and what they are doing at on-site in terms of training, education, and service delivery, and how this expansion effort can scaffold those local efforts, really raise the strengths of those local sites, but also address gaps in care delivery in a way that's feasible and sustainable. In terms of relevance, I mean, we harped on this before. I think we all are familiar, but the tremendous demands on our ERs across the state have been significant. There are certain subpopulations that we are identifying that have even higher needs. Our younger youth, or youth with neurodevelopmental disability, autism, and intellectual disability, youth with substance use, youth with med psych concerns, youth with significant trauma and attachment concerns. And so really not only understanding this is relevant, but that there's pockets of even heightened impact that we could potentially influence. It's stated here that we want to develop this by the end of FY24. In our timeline, we're looking to implement in April of 2025. So we really want to be able to have this model designed and developed and ready for implementation by April of 2025, and have some lead time to do so. Next slide.
I'm sorry, my cursor is lost.
That's
It's
okay.
got confused. Here you go.
No worries, no worries. So how are we going to measure success for this initial aim? So we want to ensure that with that emergency service team that we're really having an interprofessional lens. We recognize that although our primary care model is largely provider to provider based, we really recognize the important role of social work and nursing in the delivery of emergency care. So we've engaged social work and nursing partners at our pilot sites. We're also engaging administrators, and we've also learned that there are local psychiatry resources in those communities that have significant limitations, but are present. And how can we leverage that as a strength that we can integrate into the model? We also have hired a project manager and administrative assistant to facilitate this work. Our administrative assistant started this past month, and our project manager will be starting in June. We've also worked to identify inclusion criteria. As we've been talking to our pilot sites, it's very clear that we need some level of local support for assessment and disposition management, and that having a site without a social worker, at least for the pilot, might be very challenging to really understand how we can deliver this service. But recognizing that there's differential levels of ability to engage other disciplines, and being mindful of how we'll engage different disciplines along the way, but finding social work to be a critical part of engagement. We also need, obviously, a commitment from leadership, and that's both attendance and engagement in planning and workflow meetings, but also we're working on developing contract agreements and wanting to make sure that we get a good buy-in from our partner sites in that work. And then just understanding the culture at each site and selecting, we'll talk about this on the next slide, and selecting our pilot sites. It was really important to us to understand the culture at the site that we were.
Oh, this is Mary Lutzke. Okay, bye-bye.
So understanding at the pilot sites what that culture is around behavioral health, because we found that pilot sites that are really leaning into this work, even if they have limited resources and limited supports, are probably better sites to include in a pilot, given kind of the eagerness and willingness to engage, provide us bi-directional information, updates and feedback. on their local work and really kind of lean into this this activity. Right now, we have identified 2 systems, one urban and one rural. Those systems, one of the systems has 2 sites, a large urban site and a satellite site. The other system has a series of 5 sites, some larger, some very small, with varying levels of staffing and support. And so it really provides us an excellent sampling of sites with diverse populations and site needs. We've also engaged our state's EMSC director in helping us identify those sites. And we've also met with our project lead through SAMHSA, and we have a community of practice that's meeting pretty regularly to inform this process. Additionally, we've met with some leadership in rural ED care, and they've also informed our site selection. And then lastly, we're actively working right now on the development of an ES consultation model. This has largely been informed by site experience, but also individuals with expertise in delivering emergency psychiatric care, individuals with expertise in teleconsultation, as well as individuals with backgrounds in DEI and suicide prevention. And we're really keenly thinking about timing of the delivery of the service, how to liaison with different members of the team. We have a model that's not exclusively just for the provider, but really thinking about integrating the social worker. We also want to be inclusive of the nurse because oftentimes the nurse is at the bedside. So thinking about how to engage nursing, but recognizing we need to kind of consolidate the pool of individuals we'll be directly interacting with. And then we are actually right now starting to map out workflows with these sites. Next slide. So in terms of, identifying partners and sources of information, we have a very strong partnership with our Department of Health and Human Services that's been tremendously supportive. We have regular meetings with leaders in MDHHS and other key stakeholders around the state. We also have engaged our EMSC director, and we'll be attending our state's EMSC meetings, and hopefully we'll integrate our project manager once they're online. As stated, we've talked to our other pilot sites, but also advocacy groups related to urban and rural healthcare. And then we have our MC3 team for the primary program, the primary care and perinatal program. We have a MC3 Community Advisory Committee and an MC3 Community Project working group. We have actually 5 of them to look at different aspects of our project. The other thing that's not mentioned here, but that I'll highlight, is we did do a statewide needs assessment in partnership with a public health institute in Michigan. And we're able to do focus groups with diverse providers and staff and ERs. And that really helped us understand early on what those needs are. Unfortunately, we don't have that information to share, but that was part of our process as well. And then we have a lot of rich data that we've gathered through other aspects of MC3, whether it's school consultation, primary care, or specialty practice, about the interface with the ED that we hopefully hope to bring to this work. So with that, certainly open to any questions. Also, if any member from the Michigan team would like to add anything, you're welcome to do so.
I will. Hi, it's Sam here. I will just add that we presented information about the focus groups at one of the past EIC
Yes, we
sessions.
have it. Yes, we have it recorded.
Okay.
Yep.
Good.
Yes, it's available. So just go back to our website. It's all there. Thank you. And Anne did a wonderful job. Thank you. Okay, questions for the Michigan team?
Yes, could you go back to the slide 2, like that second one that tells us what your SMART goal or SMART aim is? Okay, so you are working, just help me get this right. You're working with sites to collect data about their services, their consultation services or consultation model?
Yeah, so we're building our consultation model, but we're gathering data from the site. So right now, what we're looking at gathering data on is site demographics. So, you know, who does the site serve? What are their volumes? What does their staffing model look like? Just to really understand the basics of the site. We're also meeting with the sites in person to develop workflows to understand their personal workflow because, you know, each site is a little bit different. The nurse may have a different role, the social worker, the physicians sometimes are not involved at all. Sometimes they're heavily involved. One of our sites has a very large APP group. So we're doing that. We also have a robust teaching and education survey to understanding what they want out of training and engagement around training. And then lastly, we just met the other day to start developing another survey around just comfort and confidence and attitudes around mental health care. Um, there are a lot of systems issues that interface with the ED, and as we've been talking to our pilot sites, it's been really eye-opening to see how other issues around schools, around law enforcement and legal system, around social determinants of health, issues of stigma and bias, how that all kind of filters down into the ED. And so we really want to understand some of that as well as just general comfort and confidence with mental health. So
Yeah.
that's what that's referencing.
I
Great.
remember
Thank you.
Nasu last summer when we attended the meeting in Cleveland. They talked about the fact that it's important not to so-called laminate your model before you've gone to the site. So you're really developing it in concert with the site. And as Nasu pointed out, there are numerous systems issues in our urban site, which is in Detroit. He referenced the fact that not infrequently law enforcement will bring in youth. And what does the workflow look like for that? And how do you think about that differently, say, than, for other kids? And how are you working collaboratively with community mental health centers who are, at least in the state of Michigan, not infrequently the payers for the hospital stay? So what does that mean? And how do we interface with them? We also have on the Michigan crew a DEI consultant to make sure that in addition to sort of looking at issues related to race and culture and religion, we're sort of developing models that are sensitive to all of those needs. We have, broad populations of indigenous populations in some of our rural areas, and high rates of Black and brown populations in some of our urban populations. So how do the programs that you develop differ? And how, really importantly, do you tap into the strengths of some of those populations and sort of capitalize on the resilience?
Thank you so much, Michigan Group. Thank you for all your wonderful insights, and thank you so much to Washington Group. I do want to spend a little bit of time on the pre-questions that were shared. I shared them as I got them. So we have a number of questions from our newly joined group to our wiser joined group who've been with us in the past, such as Washington and Michigan. So one of the questions I'd like to ask from that pool of questions is how do you support EDs when you have limited hours staffing for monitoring the consultation line? Do we have anyone who can from our experts who've been at this for a while that can give or suggest some ideas? How do we support EDs when we have limited hours in staffing for monitoring the consultation line? Ideas you've heard from other states, maybe?
Hi, it's Nasu. Yeah, I think this is a huge challenge. We've talked about this internally. One of the other hats I wear is I'm a consultant to our local University of Michigan ER site. And the ER, functions 24/7 with peak volumes usually between noon and like midnight, 2 a.m. A lot of our models are typically 8 to 5. For the pilot, we made a decision from a feasibility standpoint to really design a model that was more daytime, recognizing that we may get feedback that, evening hours or shifting our hours may be required at some point. But just the feasibility of staffing a model in kind of concert with the ED, is quite challenging. And I think I'd love to hear if there's other alternative models that are feasible, but we've elected to kind of go to more of a daytime model, although we haven't implemented anything yet.
So
Yeah,
anything,
Pauline, I don't know if you want to speak to this at all, but I think just to echo that, I think these are conversations with our ED pilot project, and then also with our larger partnership access line, this, sort of 9 to 5 situation. Washington does have a couple other, not related, not part of our project, but a couple other psychiatry access lines. One of them is, I believe, is 24/7 for prescribing providers, but funded through our healthcare authority. So just, some of it is in Washington, I'm sure in other states too, is funding related. But yeah, we're definitely, these are conversations that have come up when our larger PMHCA project started talking about expanding into ED. It was like, we just don't have the capacity for that line to do kind of a 24/7 model. So I guess the hope, the pipe dream is that with, starting small with our ED consultation, that, maybe it will gain some traction and some notoriety around, maybe there'll be more funding, etc. So yeah, Pauline, jump in if you want to add to that, please.
Yeah, no, I mean, I was just going to say that just like Michigan, ours is a daytime consultation service too. I mean, we operate Monday through Friday, 8 a.m. to 5 p.m. So I rolled out a similar consultation service during COVID, and we actually found it not to be as huge of a barrier as you would think. People kind of got used to like knowing what our hours were and calling within those hours, and waiting over the weekends, and utilizing other resources. So it is challenging, but it has been functional in the past for us to just operate during business hours and still be able to provide a high level of service to the community.
thank you. Okay, I have one more question that we're gonna, I think, get through in the queue, and then the rest we'll address by email. Yes, Gabby has a question. Go ahead.
Hi everybody. This is a great question. I wonder, have you considered any pathway or protocol for the EDs to implement outside those hours, for de-escalation, safety planning, or any other emergency protocol at that moment?
I mean, I think our hope with our program is that we will eventually educate the ED providers enough and give them enough resources that they are able to implement some of those things within their own, at their own sites and with their own resources, even if they're limited, right? So that's the hope, right? That we'll provide some of that resource education to them.
Just to piggyback on that, what I found is that pathway development, if it's really driven by the local site, for common issues, can be very powerful. So, two of the more common issues that we're hearing are suicide risk, and aggression. So you could see an ED developing, with the support of the Access program, developing their own pathway in terms of management. What's first line PRN medication? What are some basic behavioral interventions? And then calling in the morning to say, okay, we went through the algorithm, it's still not working. Can you help us? And that's what happens at a lot of hospitals with in-person consultation, recognizing that 24/7 ready access to mental health providers is not always available. So it's a great comment, Gabby, that developing those kind of structures and then education will really help empower the local sites to do some of that work off hours.
Thank you.
Okay, so I think we have a little bit of time left here for one more question. For a regional approach, how do you manage outreach and use of several EDs at the same time, or hospital systems? And I don't know if we're there yet. But maybe Washington, are there several EDs you guys are already working with or beginning to work with, and how's this process going? And then for Michigan, I know you were in the beginning steps as well, but how will this look like, you would imagine, as far as staffing goes? How do your administrative, it sounds like you've hired some staff recently. What are some other challenges that you might be needed to consider in the near future?
We are just in the infancy in Washington since we launched really on Tuesday morning. So we haven't.
Oh my gosh, congratulations.
Thank you. So we haven't had those challenges yet, but I'm sure we will come across them and have better answers in the future once we are more fully operational.
Thank you. And with that, do you see, it's also a question that was piggyback off of this one, a lot of competition? If your line is housed with a children's hospital, do you see competition, from other competitors in the market?
We don't have a lot of competition because we're one of the few pediatric providers. I think what we are experiencing that we're going to navigate is that Washington State also passed a House bill recently that required our state to establish a statewide network for serving some of these patients that are boarding in the emergency room. So we're meeting with that team to figure out, where the crossover is, how we're going to partner with them, how we're going to utilize each other, right? So it's not necessarily competition exactly, but it's almost like almost a dual role, right, that we're going to be navigating. So that's going to be our next interesting conversation to have.
Thank you. And Michigan?
Well, I can add, and others on our team can certainly speak to this, but one thing in terms of the competition piece that's been eye-opening as we've engaged our stakeholders is recognizing that they've kind of learned who their psychiatry partners are in the community or may have some limited access via phone or some other mechanism. So understanding, as Sheila mentioned earlier, how to utilize those strengths and capitalize on that, and recognizing that this doesn't have to be a conflictual relationship. It actually can be very synergistic. And so that I think has been really important to understand, and how we can leverage those local resources. The other thing that I think has been really important to us, we're one of many academic sites in the state of Michigan. So we've been trying to partner with other sites like Michigan State and some of our other partners to see how we can kind of integrate them in some of our educational and other consultative activities. And I think by doing that, we've really seen MC3 as more of a state initiative rather than, any particular program's initiative, although, many of us happen to be from the University of Michigan. So not as much competition, but understanding the landscape has been helpful.
And I can just add, as far as regional resources, we're really building on our strong statewide PMHCA program. So utilizing the resources we have in place, our statewide team of behavioral health consultants who have expertise in resources within the region. So we'll bring them into the process. I've been figuring that out, but adapting the current model and the current program. So it's not an entirely separate entity.
Thank you. Thank you, everyone. And I'm being reminded that our time with questions is up. But I do want to put just a quick plug there. We did have a question from another group that I wanted to give 2 minutes of time if anyone has this insight. So they are looking in a consultation with, in relation to consultation to EDs, the online software model like Trite, Trayt. Well, might not be saying this right, but to manage their data connections and connections. Has anyone tried? Right now they're using Qualtrics. Sounds like. Has anyone tried anything different than Qualtrics, and has there been any success? 2 minutes.
We have a custom system and it works great for us. We've seen Trait demonstrated. It looks great. There's a cost to that. We know programs are using RedCap and have had success with that.
Okay, thank you. Washington, do you have any comment on any software they're using?
We are using RedCap for our surveys and our data collection. Yeah.
All right. Well, thank you so much. We are at the time. I just want to make sure everyone has the view of the screen because I know at some point I don't remember if I started share and stopped sharing. It says Teams discussion Q&A, big screen. Is that what you guys seeing?
Yes.
Okay, perfect. All right, so with a quick reminder for the next progression of the QI collaborative steps. We would a natural progression is actually sounds like many of you have already started with PDSA cycles, plan, do, study, act, learn cycles, that you look at the changes that you wanted to make and measuring them. And then the key driver diagram drafting, it would be a natural sequence of events for the QI collaborative. We are going to have an office hour shortly, but remember, I just wanted to again say over and over, with all these tools, it actually helping you to communicate your changes, navigate your changes, and please reach out. We are available to one-on-one consultation at any time. So a quick review of Plan, Do, Study, Act. I have actually a website there to print out the tools if your team needs to use it. Do want to remind folks that we had in what we call QI introduction guide. I think it was January. We emailed and shared it with everyone. If you don't have it, please let us know. And as actually, I'm gonna attach it as a follow-up to this meeting that has step-by-step instructions about the PDSA cycle and why do we need to start thinking that way, and how do we think of improvement on the small scale, and that's something that the cycle can help, and then how do we enlarge it and make it bigger and a system scale level. So with that, this is, I am now seeing you guys. This is not a very clear screen, but again, this was shared earlier. I just want to say that the key driver diagram could be a useful tool that organizes your work, puts your wording in what I call an elevator speech that you can present at any time and share with any stakeholders at any moment. So to learn how to draft something like this, again, we'll have an office hour, which we will share in details and work on this together. And again, consultation individually is also available. So key driver diagram is a very useful, in my mind, is a visual tool. It will display what drives the work in achieving the project aim. Driver diagrams helps to convey the work of a team that the team is doing and is achieving the goals. And drivers represent the what, whereas the change strategies represent the how. So it could be as simple as what you see on the screen. Could be also, I have an example, I pulled an example, a little bit of a different approach. It could be very step by step and much more drivers. So it could be simplistic and then it could be as large as this one. So wanted to share that as well. Now, quick reminder, today is April 4th, and the projects that we are discussing and have teams join are provider to provider to ED provider consultation. Just a quick reminder that on April 18, we will be joined by teams that are working on community resources, and on April 25th, education and training. Sharing of the projects. So we will hear from those teams who are sharing and working on those lenses of the projects. What are their aims and what are their measures? So please feel free to join those opportunities as well. We have a lot of education upcoming to us, but I want to make sure that I zoom on June 25th. This is where we're going to be drafting the key driver diagram and assisting with PDSA cycles. Again, you don't have to wait till that moment. Please reach out before in preparation for July meeting in Cleveland. So the upcoming webinars are listed here. Please check out our website where you can register for them. Looking forward for more great opportunities to learn and discussions. This is a reminder for our participating teams to please, if you have not done so yet, reply back to Jonathan email earlier this month, well, actually prior month now, that you are pre-registering for the upcoming meeting in Cleveland. We need your names and your information as soon as possible, again, if you haven't done so. Thank you for your participation. We are very grateful that you continue to support this important work and looking forward to more discussions. And with that, I think we are right in time. Oh, look at this, 3 o'clock. We made it. I'm going to stop this video. I'm going to hang out for just a little bit more time for folks if you wanted to ask questions or clarify things. And before we all jump off, which I'm seeing people started, Eleni, have we missed anything from our teams who have presented?
Nope, we got everything, and the presentations were really great today. So thank you all for presenting.
Awesome. And Hannah, did we still missing some of the responses to our evaluation?
Yes, we are.
Please.
And I did put in the link as well for the registration for the Cleveland meeting that Jen had sent out.
Awesome. All right. We would appreciate you responding to our evaluation question that Hannah put in the chat. And thank you for joining us and have a wonderful the rest of the day.
Thank you.